This video highlights the role of endometrial resection and Mirena in adenomyosis as a uterine preservation. She is a previous to LSCS with heavy menstrual bleeding, diagnosed on sonography and 3D sonography with endometrial hyperplasia, polypoidal endometrium with loss of endomyometrial junction and the Musa criteria for adenomyosis of the inner myometrium. As you appreciate, we are entering by the vaginoscopic technique using the Betoki 5 and we are encountering cervical stenosis, that is the external os, and we open it by the semi-rigid scissors, taking cuts at 3 o'clock, 6 o'clock, 9 o'clock and 12 o'clock, and then enter the cervical canal. As we move forward, we also appreciate that there is cervical stenosis in the upper one third of the cervical canal as well as at the level of the internal os. Here again, using the same scissors, we take cuts at 3 o'clock and 9 o'clock to open up the upper one third of the cervical canal and the internal os. You can appreciate the amount of fibrosis, and we are entering the isthmocele, and now we enter the cavity atraumatically, and you're seeing endometrial hyperplasia with polypoidal changes on the anterior wall as well as the posterior wall, and then adhesions at the level of the internal which are flimsy. We just cut open so that we are able to pass in the 18 French resectoscope. Now over here, when we pass the 18 French again by vaginoscopic technique, this is the plasma kinetic 18 French resectoscope. We again see that there is endometrial hyperplasia. We extend the loop. The technique is extend the loop up to the fundus, hide the loop, now activate current and simultaneous withdraw the loop towards the surgeon, removing a chip. One more technique is you can move the scope also along with it so as to get a better chip. The entire idea is to remove the hyperplastic endometrium and the myometrium below it, and we go sequentially from the posterior wall to the lateral wall, removing the endometrium. All the glands have to be removed completely. You can now appreciate that there is adenomyotic tissue, and adenomyotic tissue, mind you, is quite sticky. You can see the glow of the plasma there, and this is the plasma generated by the sodium vapors and which cuts the tissue. We use pure cut current over here, and the principles remain the same. Hide the loop, activate current, withdraw it up to just short of the interloss, and then elevate the scope. These four movements help in removing large slices or chips. As you see, we go slowly and steadily on the posterior wall till we reach the myometrium. You can appreciate the hypertrophic glands there, and we remove each and every part of the gland, because unless we remove the glands and reach the myometrium and remove about 2 mm of the myometrium, the Mirena is not going to act properly. This yellowish brownish zone which you are seeing is the adenomyotic tissue. The problem here in this particular patient is hyperplasia. So first removing the hyperplasia and then the myometrium. So many a times we use thinning agents to thin the endometrium. Some people do a DNC prior. You can use the tissue retrieval system to do a visual DNC, or we can give even GnRH initially to thin out the endometrium and do endometrial resection. We now move on to the anterior wall. We go as close to the fundus as possible, dig ourselves inside, and here you can see the yellowish brownish vapor pockets that are created because of the adenomyotic tissue, gradually removing each chip and keeping a constant watch on the fluid that has been used. This is normal saline which we are using. We are using an endomat at a irrigation rate of 200 ml per minute and a pressure of 100 mmHg. You can appreciate how slowly we go dig in and remove each slice and go beneath the endometrium and remove the myometrium. Once the bubbles accumulate, the trick is to take the scope within the bubble, open the outflow, and start the suction so that the bubbles are drained out and the vision becomes clear. All this reddish endometrium will be removed and be replaced by white looking myometrium. Be careful at the fundus for not pushing the scope too much in to prevent any kind of perforation. It's always difficult when the chips get accumulated. You can always remove some of the chips and again revisit it, the cavity, but the problem remains once you come out of the cavity, the vision becomes very poor. So we make it a point to finish the entire endometrial resection by pushing the chips to one side and getting clear vision and keeping the entry of the resectoscope to only a single entry. Here you can appreciate the glow of the plasma. It is the current that ionizes the sodium particles, dissociates the NaCl into charged sodium particles, which creates the vapor pocket, and then this vapor pocket causes the destruction of the cell wall, completely bursting the cell wall, and therefore causing the cutting. Gradually, as we move down, we take small ice cream scoops to remove the tissue. So we don't take deep bites then because the purpose is to remove only about 2 mm of the myometrium below. All this tissue will be then sent for histopathology for evaluation. Here you can see how we take small ice cream scoops to remove the tissue at the fundus. This is very, very tricky. Another technique is you can use a roller ball loop over here to vaporize the fundus so that the chances of perforation considerably decrease. Now you can see all the tissue within the cavity, and this we will remove partially with the loop and then with the ohm holding forceps. After having done this, we then insert the Mirena and then put in again the Betoki scope to reposition the Mirena to the fundus so that it should not be expelled. You can appreciate the grasper pushing it up to the fundus and seeing the stem within the cavity completely. Here you can see that we are pushing with the grasper, even the stem to reach the fundus. So it is properly located. The time taken 30 minutes and the fluid absorption of 750 cc of normal saline. Thank you so